Pleasure to be here. It's always a feeling of honor to be invited to speak, and especially when that invitation comes from trainees. I really feel very privileged. So today I'm going to talk to you about a lot of the stuff that I work on in my lab, particularly focusing on precision strategies for screening to identify groups of people who would benefit from prevention and who would benefit from early detection of endometrial cancer. So I feel like this is a great talk to have right after the previous one because a lot of those concepts are going to be repeating. Just briefly, endometrial cancer is a cancer that starts in the inner lining of the uterus. It is the most it makes up the majority of uterine cancers, and it's also, the most diagnosed cancer in the developed world: Canada, the U.S., the UK, Western Europe. As the previous speaker mentioned, the incidence of endometrial cancer is increasing year after year, and as well as the mortality. It is the fourth most commonly diagnosed cancer in women, or people who identify as identified as female at birth, following breast cancer, colorectal cancer, and lung cancer. Surprisingly, however, most people have never heard of endometrial cancer, and if asked about gynecologic cancers, would name the ovary or cervix, but would not think about endometrial cancer at all. And this pervasive lack of awareness has been documented in various quantitative and qualitative studies in the literature, including our own here in my lab. Most endometrial cancers are diagnosed at an early stage while the cancer is still confined to the uterus and can be cured by hysterectomy most of the time, which results in excellent patient outcomes. However, the survival significantly drops when diagnosed at later stages as cancer spreads beyond the uterus to other organs. And this highlights the importance of early detection. As previously described by Tina, there are two major types that have been historically documented, or two pathways for carcinogenesis that have been historically documented for endometrial cancer. So the first one is the most common one, which makes up about 80% of endometrial cancer diagnosis, is the estrogen-driven, where estrogen, without counterbalancing progesterone presence, promotes the continuous proliferation of the endometrium, which results in gland crowding and the development of hyperplastic conditions that can acquire oncogenic mutations such as PTEN, for example, and others, which would develop into atypia. And atypical hyperplasia is a precursor to low-grade endometrial cancer, and could develop to cancer in 50% of the case. In fact, atypical hyperplasia is often present or discovered concurrently with endometrial cancer as well. The second type is the non-endometrioid, or the less common type, which is characterized by high-grade, more aggressive tumors, and comes from a completely different precursor. It's fair to say that we don't know very much about the precursors that result in the high-grade, non-endometrioid, and the more rare types of endometrial cancer. So the risk factors that are most associated with cancer have been obesity, metabolic disease, nulliparity, early stage at menarche, late menopause, family history, infertility. And if you just look at the first column and the second column, where people have looked at the risk factors by type of endometrial cancer, you see that many of them are the same. protective factors are in green: oral contraceptive, cigarette smoking, physical activity. There's one thing that's most commonly detected in the type 2, which is a high dose of tamoxifen. And I think the previous diagnosis of breast cancer is also associated with a type 2 diagnosis, and which was interesting. So when a study looked at whether or not the type 1 and type 2, even though we say that they come from different cells of origin and different precursors, but they have similar risk factors, and most of them are hormonally associated, which puzzled people. But this was probably a more recent study that also looked at molecular classification lens, highlights that probably a lot of these histotypes, which are used to decide if a cancer is in type 1 or type 2, are not very reliable, right? In the presence of molecular classification has provided a more objective way to classify endometrial cancer and define more homogeneous subgroups that are characterized by very specific mutations. And in fact, that paper that looked at etiology with molecular subtype lens highlights the fact that there actually may be even more pathways to oncogenesis than 2, right? Depending on what mutations are acquired when, and that would influence the disease trajectory. So a lot more work is going to be happening in this area now that we are looking back at things with this molecular classification lens. So one thing important to note is that there is no standardized screening test for endometrial cancer. Currently, there's a diagnostic test, which is the endometrial biopsy, and it's only recommended for people that present with abnormal uterine bleeding. And that is usually, in 90% of the cases, the first presenting symptom of endometrial cancer. So what is abnormal bleeding? It's any postmenopausal bleeding or any abnormal premenopausal bleeding. And the current guidelines is to recommend an endometrial biopsy for anyone who is over the age of 40 with abnormal bleeding, and anyone before of the age of 40 if they have any risk factors. But the endometrial biopsy it's a fairly invasive test. Some of our patients some of the patients that we've talked about who have gone through this in one of our studies described it as barbaric. It is very painful, and it does not have great acceptability to be used for surveillance and in a screening program. Moreover, even though it's used as a diagnostic test, its sensitivity is only 89% and misses about 11% of the cases that would have a normal biopsy and would later be diagnosed with endometrial cancer. And furthermore, abnormal bleeding is a non-specific symptom where people that have abnormal bleeding, when we look at how many of them get diagnosed with endometrial cancer, less than 1% perimenopause and less than 10% postmenopause. And that highlights a big problem. So we do over 10,000 endometrial biopsy every year in British Columbia to diagnose roughly 1,000 endometrial cancer. But also to compound this, only those that have have abnormal bleeding would be recommended this diagnosis. And we know from the literature and also from our own study that women often delay seeking help for their abnormal bleeding. Either they're unaware of it being a risk, an important consideration, or would just simply delay seeking help. So in a study that we've done at our lab, a qualitative study, we looked at awareness and delays in seeking care for symptoms that arise during perimenopause and menopause, and we saw that there's a lot of confusion between all of the gynecological cancers. And so when we asked them about endometrial cancer, our participants would often cite things that are related to cervical cancer. They would feel protected because they're getting their pap screens done. They feel like they are already doing everything they could, but meanwhile, we know the Pap screen is not a screening test for endometrial cancer at all. Also, many women attributed their symptoms to perimenopause and menopause and often delayed seeking help until the symptoms persisted for a long period of time. And finally, many women had the attitude that they needed to tough it out. They needed to deal with their own symptoms during midlife, that these things are normal, and did not want to bother their healthcare provider, and have felt previously dismissed, having dismissed from their provider, dismissing their symptoms and what they experience to menopause. So as Tina mentioned in the previous talk, endometrial cancer is a disease of inequity. So even though we often say that it's most common cancer in the developed world, actually when we look at the increase in incidence rate globally in the last 30 years, we see that a lot of the developing countries are witnessing increases as well, with an increase of 49% in sub-Saharan Africa, 56% in Latin America, 75% in the Middle East and South Asia as well. We're seeing increases. And this is probably linked to the increased epidemic of obesity with the adoption of Western lifestyles and ways of eating and moving and so on. Also, we know that in higher income countries relative to low income countries, there's a delay, in low income countries relative to high income countries, there's a delay in between the time from symptom onset to seeking help from a health professional. There's also delay in the time it takes to have a definitive diagnosis. And there's lack of access to medical staff and nurses and treatments such as hysterectomy and chemotherapy for those diagnosed with cancer. We also know that that this disease disproportionately impacts underrepresented groups. In the previous talk, we saw how race is a big factor, including Black women being more likely to be diagnosed with the more aggressive cancer, as well as more likely to die from the disease due to either systemic racism in how care is provided, or due to other factors. For example, we know that often Black women will have a higher incidence of fibroids, and often abnormal bleeding may be attributed falsely to those fibroids as opposed to being diagnosed quickly as endometrial cancer. There's also gender diverse individuals experience equity. Most of anyone with a uterus is at risk of developing cancer. And for those who identify as transgender, they may not be aware of that. They may think that any hormonal treatment that may be taking is preventing them, but they are actually still at risk. Finally, women with obesity are a vulnerable group as well, and obesity being the most common symptoms. These are the women who are at the highest risk for endometrial cancer, but they often are very much stigmatized and would avoid seeking a gynecologist for any pelvic exam or any consultation because they feel fat shamed and there experiences a lot of bias as well from their health providers. And all of this to say, there is a silver lining. This disease has been recognized to be a preventable disease in at least 60% of the cases, right? And we have very effective prevention interventions. For example, a hysterectomy is preventative, but currently it's only recommended to those who have genetic risk factors like Lynch syndrome, because they're at an increased risk of 10-fold increased risk of developing cancer. But we also know from studies that bariatric surgery is effective as well. Lifestyle changes like a reduction in BMI and body weight and an increase in physical activity would also have been demonstrated to reverse a lot of those risks. And finally, chemo prevention with, progesterone therapy to counteract unopposed estrogen, particularly in those who have obesity, are very effective strategies. This could be administered orally with progesterone pills or using LNG IUDs, as a previous talk mentioned about preventing ovarian cancer. This has actually been shown to be not only very effective in endometrial cancer at preventing the precursor, but even preventing early stage and early rate disease as well. Also, there are a lot of other chemo prevention strategies that could include obesity drugs, for example, like all of the GLP-1 drugs that are currently gaining in popularity, as well as many diabetes drugs such as metformin. So this is really a very a good silver lining in many ways. And so because of the pathway that it takes and because of the, mutations that start arising earlier before the onset of symptoms, there are opportunity to detect the cancer before it even begins or before it even forms and reverse the trend and reverse the risk, which is very exciting. And that's what I've built. The mission of my lab is to use risk-directed screening for prevention and early detection, and also to increase awareness of endometrial cancer through knowledge translation initiatives. And we had basically three important questions with clinical significance. The first one is, can we improve the recommendation of who should get an endometrial biopsy, or put it in a different way, who can safely forego an endometrial biopsy? And the second question is, are there any non-invasive techniques that can be used to detect endometrial cancer without having perhaps to go through an endometrial biopsy, maybe to detect it and to surveil it? And then finally, can we identify a group of asymptomatic people who are at risk and who could benefit from prevention interventions, especially that they are so effective? But, obviously, we don't want to apply these screenings to everybody in the population. It's important to do risk-guided interventions. And why is that? Well, because you only want to give treatment for those who stand to benefit from it. And that's the definition of what precise interventions are. And that would increase the acceptability of these interventions because we are not subjecting people to a lot of anxiety and stress of having to deal with a potential diagnosis. And it would also, most importantly, make these interventions very much cost effective. And that's what we decided to do. So first of all, before I continue talking about risk-guided interventions, I wanted to take a moment to define differences that we often kind of sweep under the rug, but that are really important. And those are the differences between relative risk and absolute risk. So relative risk are types of risks that we may get from, let's say, a Cox proportional hazard model or a logistic regression. And it basically measures the chance that a person free of cancer with given risk factors will get cancer compared to those that don't have those risk factors. And that's the definition of relative risk. Absolute risk, on the other hand, is the chance that a person free of cancer with given risk factors will get the cancer within a specific time period. And again, there's no comparison to be done with anybody else. It's just their absolute risk. And this absolute risk really depends on baseline risk in the population as well as competing risk. And the models that we use should take into account those factors if we want to use risk to direct interventions. And that's to say, the reason why it's important to account for it is because the baseline risk in British Columbia may not be the same as the baseline risk in the UK, for example, right? So we have to adjust for those measures while we're computing. So the first way we used to assess risk is epidemiological risk models. And the advantage that risk models have over individual risk factors is that we could combine multiple risk factors together, right? Not just consider obesity, for example, but consider obesity, exposure to hormones, things like that, all at once. So currently, there are 5 models that use epidemiological exposures to assess the risk of endometrial cancer. At the time when most of my studies were designed, there were only 2, but you could tell that 2 new models came up in 2023, which is really interesting as they're gaining popularity now. But you notice that a lot of these have been developed in white women, women over the age of 50. And we know that there is an increase in incidence in premenopausal women, younger women. And so those models would not really, they have not been developed in those populations, and we're not guaranteed to generalize to the premenopausal population. We also noticed that except for this model developed by Xi, most of the models use European or North American populations. And so it is not clear, and because they've been mostly developed on white women, it's not clear that they're going to be equitable when looking at non-white populations and global populations. When looking at the different types of variables that they considered, many of these models looked at very similar ones. For example, one that's common across all of them is BMI, oral contraceptive use, and smoking status. And others picked and selected various of the risk factors, such as age at menopause, waist circumference, diabetes, hormone replacement therapy, and various other things. But many of these risk factors, for example, exclude intrauterine devices and IUDs and those that we currently know are risk factors, and were often limited to what was collected during those studies. Furthermore, many of these studies were evaluated internally and externally on independent data sets, but they were of moderate performance. So we know, even before looking, none of them were validated in a Canadian population yet. And so we know just by looking at this that they're not on their own, they're not going to be entirely sufficient to really direct the intervention. So we started thinking about, can we stack other non-invasive methods to discern risk? And so the first one that we looked at is the progesterone challenge test. So this was something that Dr. Miller recommended to me in my first year when I started working in my faculty position. To consider this test, which is 40 years old, actually, and it's been used clinically to basically diagnose infertility, to investigate infertility. And often it's referred to as either the progesterone challenge test or the progesterone withdrawal test. It involves giving a very small dose of progestogen to someone for a short period of time, and then waiting after the regimen stops to look for any signs of withdrawal bleeding. So the premise here is that if someone has unopposed estrogen, once they're given the progesterone and stopped, it would trigger like menstrual-like symptoms, right, with the bleeding, and would indicate to us that estrogen is present in high enough quantity to trigger endometrial proliferation. So that could be one way that we could look at stacking this test with an epidemiological model to see whether or not that would improve the diagnosis. So a student in my lab, Rachel Woima, looked at a systematic review and meta-analysis of the progesterone challenge test, which was investigated in many studies during the 80s, but was never adopted for clinical use. So we were wondering, like, why didn't that happen? And we wanted to look at, how did this test do in terms of diagnostic accuracy? And we noticed that It's hard for you to see, it's hard for me to see as well here, but the test is very sensitive and very specific in detecting endometrial pathology. Most importantly, I don't know if this works. Oh yeah, it does. Sort of. And most notably is when we're looking at the positive predictive value and negative predictive value. Notice the negative predictive value, meaning that is almost 100%, meaning that if the test turns out negative, it is for sure you do not have any endometrial pathology underlying. However, the positive predictive value was more variable. So I kind of wondered, what was this test detecting if not endometrial pathology? Well, it was actually detecting, in the vast majority of cases, endometrial proliferation. Now, endometrial proliferation is not a pathology per se, but it's also not normal in postmenopause, right? In postmenopause, the endometrium needs to atrophy because there's no more production of hormones. So that tells us that it's actually on the spectrum of proliferation and could be potentially a good target for prevention here as well. So progesterone challenge test was added to our toolkit. Next, we looked at the vaginal microbiome. So we know that there's a strong connection between the vaginal microbiome, obesity, and estrogen metabolism, which suggests that there's a potential role of the vaginal microbiome in the development of EC. Now, how is this, even though we kind of find this association, it's not clear which the directionality of this association. Could it be that the vaginal microbiome creates an environment that's more suitable for pathogenesis? Or is it the presence of endometrial cancer that alters the vaginal microbiome environment? Or is it even possible that both conditions are just associated with age and menopause and other things, and then the vaginal microbiome becomes a very expensive way of telling that someone is, postmenopause and with obesity? And so our question became could this be, can we discover a microbiome signature that can be used to help diagnose endometrial cancer beyond BMI and other epidemiological factors? So the vaginal microbiome was also added to our list of things to look at. The really neat thing about the vaginal microbiome is that it can be collected with minimally invasive self-swabbing methods, and so that it becomes part of this non-invasive toolkit. Finally, another test that we looked at is cell-free DNA, which can also be collected from genetic material from cell-free DNA that circulate in the bloodstream and can shed into the vaginal tract through body fluids, where it can be collected using vaginal swabs and then analyzed using deep targeted sequencing to identify cancer-associated DNA changes and mutations. And in a preliminary study done by Dr. Tinker and Dr. Inglesio from the GCI team as well, and the GCI family, they discovered that in patients that have endometrial cancer, they were able to identify all of the same mutations that were found on their tissue in this cell-free DNA. And most importantly, when they looked at age-matched cohort with no cancer, they did not find any of these mutations, which was kind of interesting. And so we thought maybe this could also be added to the toolkit to look for things. And so with that, we went back and got funding for 2 studies to investigate this. So one, the detector study, which looks at detection of endometrial cancer through risk modeling in a population that's experiencing symptoms of abnormal bleeding. And the other one, Restore, which is risk evaluation and screening to tailor prevention and reduce incidence of endometrial cancer in asymptomatic postmenopausal population who is at high risk. So I'll describe these studies right now. So currently, they're both received funding by CIHR and the Canadian Cancer Society, as well as several grants from UBC, including one from for Precision Health and a few from the Department of Obstetrics and Gynecology in the Division of Gynecology. So the RESTORE study is a study that's currently recruiting. So this is the study that's looking at identifying high-risk individual with asymptomatic and with no symptom and who are postmenopausal. So here, anyone who is postmenopause, and we wanted someone to be well beyond their last menstrual cycle. So we were looking 3 years past their last menstrual cycle to make sure that they're truly in menopause. We would evaluate their risk. And we looked at including them through two ways. One uses the risk model, and we picked one of the 5 models that I talked about earlier. We picked the Pfeiffer model because it was the only one at the time when we started recruitment that was externally validated. So we picked that one. However, we are collecting, through our risk questionnaires, we're collecting the data to compute the risk from all the other models, so we'll be able to really compare them. And so we look at their risk, and if their absolute risk is greater than 2, and again, 2% being maybe lifetime risk in the population, so we arbitrarily picked that number. And we also looked at a BMI over 35, indicating a stage 2 obesity. Once they're recruited into the study and they're consented, we collect the microbiome and the cell-free DNA using tampons and swabs. And then they are given the progesterone challenge test. After the progesterone challenge test, if they experience any abnormal bleeding, we collect another self-collection. And the reason why we're doing these 2 collections is we want to see whether or not the progesterone challenge test will alter the results that we see on either the microbiome or in the cell-free DNA, because we still don't know how the interplay between both. And so if we are going to try to use those vaginal swabs as a way to screen people to who gets an endometrial biopsy eventually, we would need to know this information. So if they experience any abnormal bleeding, this would indicate the need for an endometrial biopsy, and that's part of standard of care. This is not normal. And so they would get an endometrial biopsy, and depending on what we find, they are given either hormones or a hormone IUD. Everybody then is directed to the small steps for a big change. This is a diabetes prevention program launched from UBCO that we've adapted for endometrial cancer prevention, working together with researchers in that space through a UBC-funded collaborative grant. So we're still recruiting participants, but I'll give you some ideas about how our recruitment is going. So far, we have recruited directly 590 participants that have answered our risk questionnaires and to determine eligibility. We're also using a company called TrialFacts that's also directing high-risk participants to us. 730 were screened through TrialFacts. But after putting them and looking at those who are truly eligible, and again here for eligibility, we're looking at postmenopausal women who still have their intact uterus, who are not taking any hormone therapy, who don't have any counterindication to progesterone. And we have identified 76. These numbers, by the way, are very fluid. Like we have people that are currently still moving. So just take all of these with a grain of salt. This was kind of a snapshot in time that I looked at yesterday. So of those 76, 38 consented to participate in this progesterone challenge test trial. 12 have already completed the PCT, 13 have completed this initial sample collection, and they're about to start the PCT very shortly, so that number is going to increase very soon. And of those 12 that completed the PCT, 5 were PCT positive. And of those 5, we already know that 2 people have done an endometrial biopsy, 1 had a hyperplasia and is going for hysterectomy, and 1 had a benign histology. 1 refused the biopsy. And the other 2, they're waiting to schedule their biopsy with their gynecologist this coming week. So we're still ongoing, and we're hoping to continue to accrue until the end of the year. detector is the other study that is about to start. So this is still in the research ethics phase, but we're almost done and almost out of the other side, and we're hoping to start recruiting very soon. We already are starting to pilot with 2 gynecologists for recruitment. So this is basically, we're trying to recruit 1,000 participants who are going to see their gynecologist to investigate their abnormal uterine bleeding via an endometrial biopsy. So they're actually doing that as part of their routine care, And at that point, the gynecologist gives them information about the study and consents them to collect 2 swabs, one for microbiome and one for cell-free DNA. After that, and gets their information, and our study team then contacts them, obtains full consent, and collects additional information on their risk factors. In part of this, what we're collecting here at baseline is we're looking at everything. We're looking at symptoms. We're administering various standardized questionnaires, such as the WHQ questionnaire, the Women's Health questionnaire, and a lot of other questionnaires that to understand their awareness of cancer, their awareness of symptoms, and so on. And they're getting the endometrial biopsy, so we will get access to their pathology reports right away. And based on that, we've designed a case cohort design. Using a case cohort design, we're going to sequence all of the cases who are either endometrial hyperplasia or endometrial cancer, and we're going to match them to benign cases, 1 to 2 in a 1 to 2 ratio. And it's going to be a random selection. And we're going to sequence them. So we're going to sequence about 450. And then what we're going to do is we're going to try to correlate risk factors with pathology in the entire cohort to see if we could predict based on that, but also look at the addition of the mutations and the microbiome to see if that improves our prediction of pathology. And maybe through that, we could then say, okay, these people could safely forego their endometrial biopsy. Or maybe we'll be able to fully detect cancer in those patients who have it. So this is kind of the hope. But in addition to this, we're also doing we're adding one more step. So for those, obviously, that have either endometrial cancer or endometrial EIN or atypical hyperplasia, they're going to be directed to hysterectomy. But everybody else who will retain their uterus, we are going to be monitoring their exposure for a period of 6 to 8 months. We're going to give them a Fitbit, and we're going to administer weekly questionnaires to see what they're eating, what they're being exposed to. Many exposures we're going to look at, not just food, diet, and exercise and lifestyle, but also endocrine disrupting exposures to various factors that they may be exposed to over time. And we're going to repeat the test after 6 months to see whether or not, if we had detected any mutation initially, those mutations persist or resolve, and whether or not we could find correlative to what persists, and mutations that persist and mutations that resolve. So stay tuned, as I know this is not satisfying because there is no real results yet, but stay tuned to these results as we start collecting this data. In the meantime, what we're also doing in my lab is we are validating these risk models in the Canadian population. So we have linked the CanPath cohort, which is a Canadian Partnership for Tomorrow, including the BC Generations Project and Alberta for Tomorrow Health and Ontario Health Services. We're linked all of this data to various administrative data sets, and we're going to be trying to see whether or not we can, first of all, validate these models that have been proposed for endometrial cancer in a Canadian population, but also look at additional things, additional socio-demographic factors, socioeconomic factors, gender roles, environmental factors, and family history, because the Canadian ecosystem for data is much more rich than the studies that have been used so far to develop and validate these models. And the aim is eventually, rather than looking at static models that happen at one point in time and ignore, right? So we predict today what will happen in 5 years, but we ignore any modifying factors that happen after that. We might start looking at risk trajectories that may, take, for example, genetic risk at the time of diagnosis, and then seeing over time how that risk changes with the various exposures, things like socioeconomic status, menopause, IUD use, abnormal bleeding, lifestyles, and then stacking all these other methods, these non-invasive methods, to determine risk as well. Finally, my lab is looking at increasing awareness. So in case you don't know, June is Endometrial Cancer Awareness Month. My lab has been posting daily for the entirety of the month of June on our social media, Instagram, Facebook, and X, using campaign and messages that we prepared together with our patient community and advisory group, who looked over these messages and recommended that we actually engage with the population, with the broad population to increase awareness. So we're very grateful to them. And if you're not following, please start follow, like, and share. This is the month to do it. So this is it. Reached the end of my talk. I'd like to acknowledge everybody, all my collaborators, everybody in my lab, research coordinators, staff, patient navigators who have helped facilitate all of these studies and make sure that everything runs smoothly. I never realized how much work it would be to develop these clinical studies until we started, and it's kind of like the devil is always in the details and figuring this stuff out. So I'm really grateful for everybody's hard work. All of this is only possible through our collaborative effort. I also want to thank our patient and community partners, and particularly the participants in our studies that have contributed so much of their time and effort to help increase our understanding of how endometrial cancer can be prevented and early and screened for. So thank you very much, and I'll take any questions.